Hello, my name is Eli Alvarez. I'm chairing the Stop the Stigma EM subcommittee through the SAM Wellness Committee. I'm here with really wonderful people that I'm excited and thrilled to introduce. First, I just want to introduce Dr. Amanda Deutsch, the chair of the Wellness Committee at SAM. Also, we have here Dr. Kristen Nordenholtz, who's also the chair of the Wellbeing Committee of ASAP. And today we have two fantastic leaders that will be leading this conversation. First, I want to just introduce Dr. Diane Krivko, the chair of the Department of Emergency Medicine at Medical University of South Carolina. She's here representing the Association of Academic Chairs in Emergency Medicine, AACEM. Yeah, those two words are always like flipping in my mind. And also part of SAEM. I'm also just honored to introduce Dr. Stephanie Simons, who is the Chief Medical Officer of the Dr. Lorna Breen Heroes Foundation. She's a board-certified emergency physician, and she's advised at the National Institute of Occupational Safety and Health on the impact of well-being, a guide for healthcare leaders. Today, really, we're hoping to introduce an important effort that will get us into moving from conversations about stopping the stigma in emergency medicine as part of the Stop the Stigma EM month into actionable things that hopefully will see some better progress by the end of this year-long campaign. All right, Dr. Stephanie Simons, please go ahead.
Thank you so much. And it's a pleasure to be able to talk to a group of EM leaders about this issue. So I am an emergency medicine physician by training, and often when I'm speaking on this issue, it's to folks throughout the healthcare world. So it's nice to be home. Lorna may be known by some of you. Lorna was an emergency medicine physician in New York Presbyterian Hospital in Manhattan. And she died by suicide in the first weeks of the pandemic after having contracted COVID herself and having a rough recovery. And one of the things Lorna expressed to her family before her death was that now that she had received mental health care, she was concerned that she wouldn't be able to practice medicine. She wouldn't be able to be an emergency medicine leader. She would lose her license and lose her ability to practice in her state. And she was very burdened by this. And after her death, after hearing from first dozens and then hundreds and then thousands of healthcare workers around the country, her sister and brother-in-law started the foundation really to help move towards a world where mental health care is viewed as a sign of strength for healthcare workers, that healthcare workers have access, and that we're also addressing the operational practices and environment that drive healthcare worker burnout. And so I always like to remember at the beginning of presentation Lorna's story and the why behind what we're doing. But we also want to make sure that we're doing this for the entire healthcare workforce. There are 15 million healthcare workers in the US. And as a whole, healthcare workers are experiencing a mental health crisis and experiencing burnout. So this is from the Vital Signs report from the CDC. And it's looking really at the difference between 2018 and 2022. So healthcare workers' intent to leave is going up. Healthcare worker burnout is going up, and there are higher numbers of poor mental health days and workplace harassment in healthcare workers than in any other job area. And I don't think that's a surprise probably to anybody on this webinar, but let's talk a little bit about what we can do to make a difference in that. So we think of Lorna, but there are many other families that have reached out after the death of their loved ones. Matt Gall, Scott Jolly, Lisa Lerner, Moore Brown, and Tristan Smith here. And each one of their families has reached out and expressed that in some way, stigma around mental health care was a part of the story of their loved ones' deaths. So although Lorna's story started, the foundation started this journey, there are other families, there are other physicians and nurses and their families who have reached out along the way. And most recently, that include Dr. Will West at George Washington. This is a tweet from one of his residency classmates, and that we know from what he shared before his death and what others have shared that work environment, including medical school, residency, and training environments has a critical role to play in mental health as well. So this is actually from the AHA, American Hospital Association put out a suicide prevention guide for a healthcare workforce. And in that guide, they have really concrete strategies that hospitals and health systems can use to help prevent healthcare worker suicide. But they quote 3 major areas that impact or add extra risk to the healthcare workforce. And one is poor access to mental health. So, a standing 3 p.m. appointment isn't going to work for most healthcare workers, right? Because of the hours we work and the needs of our patients. There are the necessary stressors of the workplace in terms of caring for people on their worst days. And also, there are the unnecessary workplace stressors of trying to care for people on their work days, but being thwarted by an ineffective or inefficient system. And then stigma. So that's what we're here to talk about today. And there are really 3 types of stigma. There's internal stigma. What does it mean to me to be a healthcare worker who also needs healthcare? There's external stigma. What are my colleagues going to think about me if I need help? And then there's institutional stigma, which is what are those questions on licensing and credentialing applications, payer applications that ask about our history of mental health diagnosis and treatment, often right after they ask about felony convictions, right? That place a judgment on receiving health care and differentiates mental health care from physical health care. So when we think about at the foundation how to address some of these issues, we think about comprehensively thinking about burnout and mental health. So on the right-hand side is mental health, and we know that we need to remove those barriers to accessing care that are unique to licensed healthcare workers. We need to improve screening for suicidality and confidential access to care. On the left is burnout, and we're all in the ER. We have a patient in front of us who's bleeding. What's the first thing you do? You hold pressure. And so that's individual support. Somebody's already injured, they need individual support. But then you need to find the source of the bleeding, right? Or else the patient's going to die anyway. And so that's the systems change, is going to the source of the bleeding and changing the system that people are working in. And we need leadership and cultures that will accept these changes to make them happen. So at the foundation, we are exclusively focused on healthcare worker well-being, and we do this by accelerating solutions, advocating for healthcare workers, and advancing collaboration. I'm going to talk about each of these, and then we'll focus on one particular solution that you all can impact at your own organizations. So we have really endeavored to be collaborative throughout our work, because this is not a single organization's issue, right? This is physicians, this is nurses, this is APPs, pharmacists, dentists, hospitals are impacted, clinics are impacted. And so we formed All In Wellbeing First for Healthcare, which is a coalition of leading healthcare organizations. And that includes the AMA, AHA, and the ANA. We call them the A team, but there are a lot of other organizations: IHI, ASAP, Emergency Nurses Association, Philippine Nurses Association, Black Physicians Foundation, all work together in this coalition to help guide this work. And then we have our ambassador network, which is over 150 healthcare workers that are engaged with the foundation to make a difference and to advocate for the solutions that we're going to talk about. We've also had medical students self-assemble into the Medical Student Coalition and go after this work alongside us. So the National Academy of Medicine, the Office of the Surgeon General, and the foundation were able to get March 18th designated as Healthcare Workforce Wellbeing Day. And so this is a conference that we hold on March 18th at Johns Hopkins University. It's free for anyone who wants to participate, and it will be going on next spring as well. But this March 18th, this spring, there was a student who came to this conference and heard about the credentialing work that we're going to talk about today. He went back to his hospital at Albany Medical in New York, and he said, hey, I want to get our credentialing applications changed. I want to remove the invasive and stigmatizing language around mental health care. Well, 6 months later, in September of this year, we just awarded Albany Medical the Champions Challenge badge for making those changes. And so I wanted to tell you the story of Bobby Chapman, this medical student, to let you know that anyone can be the impetus for this change in an organization, and that physician and learner voices really matter. So we also try to really raise the voices of healthcare workers at the state and federal level. So this picture is from the signing of the Dr. Lorna Breen Healthcare Provider Protection Act, which funded 45 organizations and also established the Impact Wellbeing Campaign, which is a hospital-based campaign to improve the mental health of the healthcare workforce. One of the steps in that Impact Wellbeing campaign is for hospitals to change their credentialing applications and their peer reference forms to remove that institutional stigma. And we are also doing that work at a state-based level, passing legislation and advancing legislation now in several states to change the licensing applications in those states. So right now we are reauthorizing the Dr. Lorna Breen Healthcare Provider Protection Act, which is actually now the Dr. Lorna Breen Healthcare Provider Protection Reauthorization Act, which will extend the law for another 5 years, and it will show support specifically for reducing administrative burden. So those things that get in between physicians and healthcare workers and their patients that make it more difficult to care for patients. So once we clear that reauthorization, we'll be working on funding that support every year to continue those programs. So we do have this QR tool. If you are interested in writing your representative in support of reauthorization to continue this funding for projects and programs, this was the first ever federal legislation supporting the mental health of the healthcare workforce, and we think it deserves to continue in existence. This work has been recognized, which is important to keep the issue of healthcare workforce well-being at the forefront. And I just wanted to show this picture of Jen and Corey Feist and Dr. Vivek Murthy, our Surgeon General. They were receiving the Surgeon General's medallion, which is the highest award for public health service in the country. And so there is a recognition from around the country that this is important work and that the healthcare workforce is integral to the practice of a healthy society. That's why we are also focusing on media coverage in the lay press. So in addition to publishing academically, from time to time, we have a lay press strategy again to change the narrative on healthcare worker well-being and to really keep this top of mind for folks, especially as the pandemic becomes endemic, right? And so I think we all can remember these moments where there was applause, there were pots and pans banging, there were signs in all of our neighbors' yards thanking healthcare workers for the work that's being done and a real recognition that work is critical. That faded pretty rapidly throughout the pandemic to arguments about vaccination and increasing incivility and even violence. And so, it's critical to keep this top of mind, not only for healthcare workers, but also for the general population, so that an increase in civility can start to occur and that we're seeing a return to the safer workplaces and the recognition that we're critical to each other. So lastly, we're working to accelerate solutions, and this is where I really want us to dig in and talk about how we can make a difference. Because so often a talk about burnout, a talk about mental health challenges for healthcare workers ends with the description of the problem. And we all want to make a difference. The Caring for Caregivers program is a state-based program that allows us to implement the Impact Wellbeing Guide. So the Impact Wellbeing Guide is designed to really be able to be implemented at a hospital or a health system by itself. But what we've found is that hospitals and health systems sometimes need a little technical assistance to get through the steps. And so this Caring for Caregivers program puts groups of hospitals and health systems together and moves them through the stages of the Impact Wellbeing Guide as a cohort. So I like to call this cooperation, right? The hospitals are working together to get something done, but they don't want to get behind. And so it helps promote and propel that change at the state level. So we know that this is important because of these three forms of stigma. And we have included as one of the phases in the Caring for Caregivers program, changing the institutional stigma around licensing, credentialing, and payer applications. The reason stigma reduction is so important is that as physicians, we have this toolkit that we develop throughout our training. We are hardworking, and you need to be hardworking if you're going to get through medical school and residency and survive your practice, right? We're independent, and we need to be independent, because if you're working in a single coverage ED with 10 beds and a kid with a gunshot wound comes in, you better believe that you can do it by yourself, because there's you and a nurse, right? And whoever can get there after you call as soon as possible. You got to believe you're superhuman, because if you're cracking a chest, or even if you're delivering a preterm infant in the ER, right? That's not a normal everyday event for most people. And so you better believe you can get through it. And if you're checking orders on my kid, like, I want you to be compulsive, and you need to be achievement oriented. And all of those things are positive tools, but we have a tool belt full of hammers, and then we're asked to change a light bulb, right? And so it doesn't work so great. Being hardworking doesn't work when it's time to take off, and being independent doesn't work when you need help. Believing you're superhuman doesn't work when it's time to experience something that's very human. Being compulsive is great when you're checking your orders, but not at the middle of the night, if that's when you're sleeping, or the middle of the day, if that's when you're sleeping, when you wake up and you can't sleep because you're still thinking about those orders, or you're still thinking about that patient and their outcome. And we need to expand our achievement orientation to be more than just the next work-related achievement, but also the achievements of our family and our outside lives. So in order to recognize all of these things, at the Dr. Lorna Breen Heroes Foundation, we developed the All-In Wellbeing First Champions Challenge Badge for licensing and credentialing. So All-In, remember, is that coalition of more than 20 healthcare organizations from across the ecosystem of medicine, recognizing a state or a hospital and health system as meeting the best practice standards for licensing and credentialing, meaning that they've removed intrusive mental health questions and stigmatizing language. And that's from the licensing application, from the credentialing application, and from the peer reference forms that are part of those applications. I'm sure you have all filled out the peer reference forms. Some of those peer reference forms have the worst questions of the bunch on these. So we are also working within learning communities to get organizations through, get states through these steps of doing the licensing and credentialing, education for their hospital leaders, and then practice environment improvement. And so I just wanted to show you that we are working right now with 3 states and several more states on the way to do this en masse as a state. And what we found in Virginia, which was the first state that we worked in, is that we could get the licensing changed legislatively for all of the licensed healthcare workers in the state. That was over 500,000 licensed healthcare workers. And then we could issue a challenge to the hospitals in the state and say, hey, we want you to get the Champions Challenge badge as a state. We want all of the hospitals to be involved. And in the first 10 months of doing that, 75% of the hospitals in Virginia changed their credentialing applications to remove that invasive and stigmatizing language. This was published in the American Journal of Public Health. And as part of the work in Virginia, the largest private health system in the country, HCA Healthcare, changed their credentialing application across all of their almost 200 hospitals and multiple surgical centers. So I want to bring this up to let you know that this can be done, that hospitals will change these questions, and that they need a light touch of technical support to do so. When you have this conversation with a hospital about changing these questions, they often say, well, we have to ask these questions in this way. And so then we ask, well, tell me more. Who says so, right? Who says so? And there's a variety of answers about who says so, but these are the organizations right here who have said, it is not us, okay? It's not the AMA, it's not the AHA, it's not the Federation of State Medical Boards or the Joint Commission or the National Association of Med Staff Services or NCQA or NIOSH or any accrediting organization that we've been able to find. So that when you dig down to that, it's the hospital's own policy that says they have to ask these questions. And the nice thing about hospital policy is that it can be changed. And so it really becomes then a matter of education about what those best practice questions are, and some light technical assistance about how to change those questions, and then recognition and helping them communicate that change to their healthcare workforce. One of the questions that people ask us is, does it put us at risk if we're not asking people about their history of mental health and substance use disorder? Does it put us at risk if something bad happens? Does it put the hospital at increased risk? And I usually say, well, if somebody answers yes, how do you respond? Do you have comprehensive resources to help them and to make sure that they remain unimpaired? Do you have additional leadership development and mental health resources or coaching that you offer? And very rarely is the answer yes. And so I would argue, if somebody answers yes and you're not giving them more resources, then you're actually putting yourself more at risk, right? And you're also treating mental health and physical health as different things. So you're ignoring mental health and physical health parity in your questions. And you're also often not doing any specific question about current impairment. So we want people to ask about current impairment. If somebody's currently impaired from the practice of medicine, they should alert their employer. But asking somebody about a history of impairment or a history of diagnosis and treatment, it actually violates the American with Disabilities Act. And so in 2003, 3 senators, Wyden, Booker, and Merkley, so that's Booker's from New Jersey, and Wyden and Merkley are from Oregon, they asked the Department of Justice to weigh in on whether these invasive questions on licensing applications violate the ADA. And the answer was yes. It is clear that because these applications are a necessity for employment, that asking these questions run afoul of the ADA. And so what we're starting to see is we are starting to see some lawsuits from healthcare workers who are being asked these questions on state licensing and credentialing. And so when people bring up this issue of risk, I will say, you can mitigate your risk by asking about current impairment. You can encourage people for self-care, and you are also mitigating your risk by not running afoul of the ADA. So here's our current state of the state for MD licensing, okay? And I'm very specific with my wording on that, because there are several states that have DO licenses that have not been tracked yet. So just know that this is the state of the states for MD licensing. And as of September 1st this year, 29 states had verified licensing applications that did not include the intrusive mental health language. That's up from 17 states 3 years ago. So this change is happening, and it's actually happening pretty quickly. Over the course of just 2 years, we've seen a rapid increase. The dentists and the nurses and the pharmacists are also getting into this work. And so we have separate maps for each of them. And we are trust but verify people. So if a state says that they've made the change, we say, great, let's see your licensing application. And then we go through and we verify that change has been made, and then we award the badge. So in addition to the state licensing application, we also need to look at hospital credentialing. And before I move on to hospital credentialing, I want to encourage you, if your state has not changed their application, please consider advocating directly to your state, because we know that the state medical boards do listen to this. I'll put that QR code back up in a moment, but hospital credentialing also matters. So this map shows the states where we have been able to verify hospitals that have changed their credentialing application. And so on our website, On this map, you can scroll over each state and click on it, and it will list all of the hospitals in that state that have changed the credentialing applications for the state. As of September 1, there were 375 hospitals that we had verified that their application and their peer reference form had changed their language. There's also one insurance company and two sort of employers, Jackson and Coker, which is locum tenens, and Envision Healthcare, which is employed and contracted physician group. So we would love for this map to be blue all the way across and for every hospital in every state to have changed their application. And what we're seeing is that the pace is starting to accelerate in this area as well. So at the beginning of the year, when we updated this map, there were about 150 hospitals. Now there's 375, and we think we're going to start updating it quarterly. We think when we update it at the beginning of 2025, there's going to be over 500. So this is change that is happening, and it's change that you can be a part of. Because just like Bobby Chapman went back from a talk and went back to his hospital and got it changed, you can do the same thing. So here's how to make that happen. First of all, you need to check your hospital status. And so I will pop the link in the chat at the end of this webinar, and we can communicate it out other ways as well. But on our website, there's that map. You can click on that light blue map on your state and check for your hospital. If your hospital already has the badge, that's awesome. Communicate that your hospital has made this change. Let people know. You're not going to be asked this on your credentialing application. If you're in a state where the state licensing application has changed too, spread that word as well. Second, if you don't have the badge, find a champion. And that might be you at your hospital, or it may be the CMO, chief of staff, or chief wellbeing officer. All of these folks are great resources. Then you can educate them, use our resources on our website. The QR code I had up a minute ago that I'll put up again, links to a toolkit that walks you through the process. Submit the applications for feedback. So what I've found is that when folks try to change the application on their own, they usually miss at least one or two places in the application that use stigmatizing language. And or sometimes we've noticed that people kind of go out of the frying pan and into the fire with the way they ask. So they may go from, do you have a history of any diagnosis or treatment for mental health conditions, to, are you currently being treated for any mental health condition? Well, being treated for any mental health condition is still what I like to call a none ya question, as in none ya business, right? It has nothing to do with impairment. And so the question should be, are you currently impaired from the practice of medicine for any condition? And not specifically singling out mental health, and not asking about treatment for conditions that are non-impairing. So once you submit the applications for feedback, they'll be reviewed and feedback will be given. The applications get changed, they're resubmitted, and then you can celebrate with the badge and communicate the change. So this is the process that now hundreds of hospitals have gone through to successfully change and verify their applications. Okay, I've got a QR code and I've got the URL for those of you who don't want to scan. This is the website where you can find the maps. It's drlornabreen.org/remove barriers. And you will see the maps for each of the licensing boards that we are working with, as well as the map where you can drill down to the credentialing information. There is background information on why the need for this change on this website, the link to the toolkit, and the submission portal. And this QR code will take you directly to the toolkit. You do have to create a login when you get there, so don't be surprised when you see that. But once you log in, you'll see there's just a plethora of resources there, and really a step-by-step guide on how to get that work done. I would love to keep this screen up for a little while, but I'm also interested in any questions that you all might have, any comments, and maybe we can keep the screen up for a little while we take those. So Diane, what were your initial thoughts and what are your questions after hearing that? And then happy to take any questions from the group in the chat.
Yeah, well, first of all, Stephanie, fantastic job. So for everyone, Stephanie and I have known each other for 20 some years back at University of Michigan when she was a resident and I was attending. So we are kind of re-meeting now. And I am just absolutely proud of the work you're doing. It's just fantastic and phenomenal. So thank you, first of all.
Guys, is there anything better than like the cool attending that everybody looked up to telling me 20 years later that she's proud of you? Seriously, thank you, Diane.
Oh, you're welcome. My pleasure. Now, here's interesting. When we met a couple of weeks ago, when we re-met a couple of weeks ago, and I heard about this program, which frankly I did not know about, I'll be honest. I thought, what a really cool thing to have a Wellbeing First Champion certificate. And then I looked on the state of South Carolina, and I was embarrassed to say MUSC was not on there at that time. So I immediately contacted my director of health, wellness, health, and well-being, and our CWO, and said, I really want to be on that list, and sent them the links and said, let's do this. So that was my step in kind of what I am doing to make this happen for us. So
Thank you.
yeah, we'll make it happen. I love it.
I love to hear that. And, you know, you all have a wonderful CWO and somebody that was really leading this work in their previous institutions. So I have every faith that maybe not for the January update, but the next quarter when we do the update, that we'll see MUSC on there, and we'll throw our own personal celebration, and I'll send you an email and it'll have lots of emojis on it, Diane.
Awesome. Awesome. I love it.
Do that. That's great.
Love it.
Yeah.
I love how you're able to already, Diane, leverage some of the leaders of your institution. And so that is like a very chair move. I see a problem. Let me reach out to people who can actually make some changes here rather than doing the work from like the beginning. I wonder, Stephanie, I'll ask you the question. I wonder, what are some common barriers that people encounter when they do this work?
So the first barrier is just a lack of recognition of why it's important, right? Hospitals are facing a lot of different competing priorities, and getting the bandwidth to make this a priority for a short time is really important. And that's one of the reasons we started doing the statewide coalitions to move the work forward, is it puts it on the priority list, right? So ways to overcome this is really to share some of the data around stigma, and stigma as a driver of healthcare workforce suicide, and stigma as a driver of the number 2 driver of why healthcare workers do not get mental health care. The number 1 driver is, I can't get there. I don't have the time. And then the number 2 driver is, I'm worried what people will think. So that often can be very powerful. If the hospital has invested in any mental health resources for healthcare workers and they're not happy with the utilization, nobody uses the EAP, nobody uses the psychiatrist that we put in place for the med staff, say, well, this may be one of those reasons why, is they don't want to have to report that the next time they credential, right? And so it starts to make sense for people. The second barrier that I see coming up is the issue of risk, which I addressed, is somebody on the legal team will say, we have to ask these questions. Otherwise, if one of these, and I'm going to use air quotes, so if you're listening to this, just know that I'm using air quotes right now. If one of these bad doctors, heavy air quotes, does something that hurts a patient and we didn't ask, then we're going to be liable for that. And that is in and of itself a stigmatizing statement. To say that somebody who has a history of diagnosis and mental health treatment has an increased risk of harming a patient, when in fact we know that healthcare workers are human beings, have a 20% lifetime incidence of mental health issues, of a mental health condition. And so 20% of your med staff are going to have a mental health condition. Okay. Are the ones who are diagnosed and treated more likely or less likely to have ongoing impairment? Well, they're less likely. And we know that asking the question is one reason why people don't get diagnosis and treatment. So if you could ask this question and harm patients. And so when you start to talk about that and then combine that with the ADA concerns, the risk department tends to start to think about this in a different way. We also have the policy advisor from the AMA who is always happy to meet with the risk departments from hospitals and really go over this. Sometimes when the lawyers talk to the lawyers, the language barrier goes away and they understand each other a little bit better than when a doctor and a lawyer are talking to to each other. And for those of you who are MDJDs, I think you must talk to yourself a lot because, you know, I have nothing but respect for that particular combination of educational experiences. The last way, and this gets a little wonky, the last way that I've seen this become a barrier is when the hospital uses the state Department of Insurance application as their credentialing application for delegated credentialing. So that is to say the hospital credentials a clinician with the insurer's application so that they can use the same application for the insurer and the clinician doesn't have to get credentialed directly with the insurer. Okay. In those, most of those Department of Insurance applications are just fine. They're pretty minimal. Every once in a while, they'll ask a question in a way, excuse me, that contains stigmatizing language. And what we've done in those cases is we've gone to the State Department of Insurance, engaged them in a conversation, and every time they've changed the question. So, and sometimes it's a little bit like playing whack-a-mole to get down to the very reason that the hospital says they can't do it. But we've never not been able to get down to that level and actually get it done. So we're happy to work with folks when those barriers come up.
Stephanie, there's a comment in the chat that I think is awesome. So I'm going to read it. It says, thank you. Great information and such encouraging statistics about the changes. I love the steps for certification are so accessible. Melanie Williams sent that. And I agree. You guys made this very like bullet pointed and so helpful. It's not a link you go to and then don't know what to do. This is really actionable steps. So I reiterate what she's saying there.
Well, I'm an ER doc, you know, it's like, we should, the one thing we should have is a mnemonic for it, right, Diane? We should have like, we just need a mnemonic and then we'd be all set. But no, really, this is practice, not theory. We really want these questions to change. We really want people to know about it once they've changed. And so we're trying to use all of our change management knowledge, how things really get done in hospitals, how a champion can move things at their unique institution. And so I appreciate that comment.
So the question is, obviously, places like MUSC, University of California, University of New York have these champions, but a lot of places in the United States have community hospitals or critical access hospitals, and they might not have a wellness champion. And in fact, who knows? I don't know of any studies that say that maybe critical access physicians are more at risk for being unwell, which it just seems to me they might be because of the stressors. What do we do in cases like those if we're trying to make changes with this? If there's no wellness champion to speak to the C-suite about or the hospital to change their applications?
That's a great question, Rita, and thank you for the question. It does not take a wellness champion. Only about 10% of hospitals in the country have a chief wellness officer or a well-being champion. In the 90% of hospitals that don't, it takes two people to make this change. It takes a champion who can be anybody, and it takes the head of med staff services who actually makes the changes. So that champion has been the chief medical officer, has been a medical student, as you heard from Albany Medical, has been an attending, a resident, has been somebody who is 100% clinical, has been a chief or a chair. We've had all sorts of people champion this work, and usually they take it to the med exec committee as a first place to have the conversation. Sometimes they take it straight to the CMO. Either one of those pathways can get the job done and get it done quickly. I just had a chance to award the Champions Challenge badge in person to a hospital in the thumb of Michigan. For those of you who don't know, right, Michigan looks like a hand, and way out here in the thumb is very deeply rural. And so I drove out there, gave them the badge, congratulated them. Their entire med staff was there of 40, and that included the clinic, and the president of their hospital is a 0.5 FTE family medicine doc. And they did it in 24 hours. All right. So in some ways, the smaller the system, the smaller the hospital, the fewer barriers there might be, right? This person considered it deeply, did some research, read our materials, and said, I think we could do this, and got it done. All right, so it's definitely an all sizes welcome, and all different organizations can do this. And honestly, it's not just for hospitals and health systems either. Like often medical groups will have their own internal credentialing. So if you're employed by a medical group, they should take a look at their applications. If you work locums ever, you should talk to your locums provider and they should change their applications. And this really needs to happen everywhere before it can be at its most effective.
Stephanie, if I can, out of my own curiosity, but also to give a national shout out to that hospital system,
yeah.
since I grew up in the thumb of Michigan, I'm curious to know who is that who got that done in 24 hours?
It was Surer Health in the thumb of Michigan, Surer Health by
Sure.
Caseville.
Oh,
Diane.
Kaysville. Yep,
Yeah.
that was about 30 miles from my hometown.
Oh, I love it. I found out where Pioneer Sugar was made on the way out there. It was
Cairo,
great.
Michigan, that's my
Yes.
hometown.
Very good. Yeah, so it was just a remarkable example of having a physician champion who wants to do something for their organization who made the change happen. So it was really wonderful. Kristen, you've been very patient.
Hi, everybody. Well, this is fantastic stuff. I know we've been talking about this. I give L.A. Alvarez a ton of credit for getting all these different silos unsiloed and talking on the same page. This is really quite a feat. So congratulations. I am very embarrassed to tell you that Colorado, which is where I practice and live, is not even on there as a state. And certainly my hospital, unfortunately, is not on there either. You've given us some great tools for how to do this at a hospital level. And thank you, Rita, for the question about critical access, because of course, Colorado has a lot of rural areas, which that's a big deal as well. But in terms of the state, how do you, and I haven't looked at the toolkit yet, so I apologize, but how do you envision us maneuvering at a state level? I obviously I'm ACEP and I'm the well-being chair this year for ACEP. So I'm going to take this to Colorado ACEP and I'm going to get those guys, I'm sure are going to get very motivated, and we're at the legislature all the time. So we'll be down there doing our thing, but this isn't just emergency medicine, right? This is the whole house. So how do we do this on a state level?
So there's a few different ways. The first way is to contact your state medical board and do some education and advocacy, direct education and advocacy to your state medical board. The very nice thing in that case is that the Federation of State Medical Boards, their member organization, has best practices around these applications for state licensing that are consistent with our best practices. We work together with the Federation of State Medical Boards. So if they just want to change their application to the recommended Federation of State Medical Boards application, they're going to be fine. But there's a different way that I like a little better because it brings our teams along with us. And that is to utilize your state legislature. And there's language that has been passed in 3 states and is on the books for this year in 4 additional states to say you can't use invasive and stigmatizing language about past mental health for any licensed healthcare workers application. Okay, and that brings along our PA and NP colleagues, it brings along our nurses, it brings along all of our pharmacy colleagues, right? PTs, OTs, RTs, all the T's, right? And so there's also an argument, by the way, also dentists in there, probably also vets could be interpreted as healthcare workers in the state. I think they should be. And I think the same arguments sort of apply. I want my vet to be able to have a diagnosis and mental health care without fear of their licensing application too. So that language is available if you're interested in pursuing that strategy. ASAP, the Ryan McBride, who's the ACEP national policy leader, he's the representative from ACEP on the All In Coalition. And so, he'll have access to all of that language, but I'm also happy, Kristen, to serve as a resource in advocacy at the state level there. And I like the state approach because going to each of the boards separately, even if they are open to change, that is like a 3-year, 4-year campaign of strategy to get them to change. And whereas passing a bill is shockingly easier than I ever expected in a lot of these ways, particularly if the doctors and the nurses and the hospitals all agree on it, like most of the time that'll pass. So getting the Hospital Association for the state, the Nursing Association for the state, and the Medical Society for the state to come together and say, yeah, we all want this to pass, and then getting some language introduced, finding a sponsor and getting it done. I was just going to say, if you had told me 5 years ago that I was going to be doing state and federal advocacy, by the way, I would have laughed because I was never like an advocacy person. And it turns out you just need something that is actionable that you care about and you're willing to go and do. And so this has been a real education for me about how things work at the state and the federal level, and particularly in these bipartisan coalition type issues, things can happen pretty quickly. Sorry, Eli. Yes, go ahead.
Oh, no, yeah, two things. Kristen pointed out in the chat, have you considered the Leadership and Advocacy Conference from ASAP? I think as a way to leverage that platform. And maybe I'll follow that with a question of oftentimes, and I learned this when Amanda and I started working on this 3 years ago on creating the Stop the Stigma EM month, is that even I was on this camp, like, well, I have not seen a therapist, or I don't even know where to begin with this. And so there might be something here that divides folks with thinking that you have to have a diagnosis to be an advocate for this. And I wonder if there's a way for us to consider mental health care as simply just, this is Amanda, it's like just going to the dentist twice a year, where you don't necessarily have to have like a cavity. It's just a way for you to prevent a lot of these things that we deal with as physicians. Is there a way for us to incorporate that in the work that we do so that we can be a lot more proactive?
I love that proactive approach. And, many people, but not all people who have practiced medicine, like if you ask them about if they've experienced burnout, they'll say like, which time would you like to talk about now, right? But not everybody. And, a fifth of people will have a mental health condition during their lifetime, but not everybody. That doesn't mean that everybody can't be advocates for the health of their community. And so I would encourage all EM physicians, certainly, as particularly given the rates of burnout and mental health conditions in our specialty, which is we're number one, guys, come on. Like, we need to be looking out for our community. And so regardless of whether you personally experienced a mental health condition, personally experienced burnout, personally experienced suicidal ideation, you can be an advocate for your community on this.
Renee and I hope I'm saying your name correctly, says, hello, I'm a state suicide prevention coordinator. I'm here because I was contacted by a physician who wanted to do something about physician suicide prevention. This is a great recommendation. I'll make sure to pass along the information. My question is, from a state public health and community suicide prevention task force point of view, do you have any recommendations on how best to support the physician suicide prevention effort?
Oh, that's such a great question. So, I think starting with that AHA suicide prevention guide would be a great place to start. And then you can start to follow the reference bunny trail on that guide in terms of the resources they used. The American Foundation for Suicide Prevention, AFSP, has a wonderful chief medical officer, Christine Moutier, who would also be a wonderful person to talk to on this. When we talk about suicide prevention, again, we talk about removing barriers to access. So that's the stigmatizing language on licensing and credentialing. We talk about enhanced screening, and the American Foundation of Suicide Prevention has a screening tool called the ISP, which is the interactive screening program. And you can back that, it's anonymous, which is helpful for healthcare workers. And then you can back it up to healthcare referrals for folks who screen positive. And then last is to make mental health resources available to healthcare workers. So removing those barriers to access. When people have a mental health condition, when they have a substance use disorder, having a high quality care option, which helps them to preserve their license and get treatment, is critical. So a well-functioning healthcare professional health program that it maintains their license, maintains their privacy, and gets them treatment is very effective, and also a very compassionate way to help do that. And then frankly, it's a lot of the same things, Renee, that also help prevent suicide for the general population, like thinking about access to firearms and having peer supporters and having really great support network within their work, but also within the community and their home. So thank you for that question.
I think I love this. Thank you continuously for doing this and being here today. Even though we're hoping to be on that proactive and making moves now, med students, letting everyone know, because I think this, even listening to Diane today, this is still not well, even though it feels like it should be, because this is so, so important. So I'm just continue to be amazed by the work you're doing. Thank you, Stephanie, for being here.
Well, it is absolutely my pleasure. And if anyone who is listening has questions, they want to learn more, if they want to become an ambassador, I encourage you to look, first of all, at the website at drlornabreen.org. The website has how to take action for individuals and for organizations, and all the links for becoming an ambassador, starting a student coalition, all of those things are there. If you have any questions and you want to talk to a human being, my email is Stephanie, that's STEFANIE at drbreenheroes.org, and I'm happy to get communications. Just remember that it's spelled like with an F, and I'll just tell you that my mom was a big fan of Stephanie Powers from Heart to Heart in the 70s. That's how I got this spelling, and now you'll remember it. All right. I appreciate everyone's attention, and I already see some advocacy coalitions starting in the chat. So I will look forward to connecting with you, and also by seeing the good work as the applications come in.
Stephanie, keep up the great work.
Thank you, Diane.
This is fantastic. Great job, you guys. Really, really.
Yeah.
Thank you.
Thank you so much, everybody. We'll keep in touch. Again, truly thank you for all the work that each and every one of you are doing. Bye, everyone.
Bye-bye.